Okay, beta. So today I'm going to discuss endometrium in the infertility. It is very important topic. At the end of the discussion, again, we will think that the role of endometrium is overrated or its ultimate master playing role in the implantation. So today, what points we are going to cover are the chain of events in the endometrial cycle, the evolution of the endometrium by different methods like ultrasound, hysteroscopy, HSG, saline sonography. What is implantation? What is endometrial receptivity? How is the endometrium in the letrozole and clomiphene cycle? How is the endometrium in hyperstimulated cycle? What are the problems with the hyperstimulated cycle? How do we prepare endometrium for FET cycle? How to manage thin endometrium? What are the problems with the thin endometrium? And what if there is a persistent thin endometrium? How to test the receptivity of the endometrium by various tests of the endometrial receptivity assays, and treatment of recurrent implantation failure in a view of endometrium. So the endometrium, basically, that's the inner lining of the uterus, and which plays a very vital role in various functions. There are three phases of endometrium. The proliferative phase, which is regulated by estrogen, secretory phase, which is regulated primarily by progesterone, and menstrual phase, which is a shedding of endometrium with the initiation of activation of the progenitor cells, which are present in the endometrium and which initiates the regeneration of the endometrium for the next cycle. There are two layers of endometrium, the basal layer and functional layer. The basal layer is responsible for regeneration, and functional layer is for preparation of the implantation. There are presence of multipotent stromal stem cells, epithelial progenitor cells, and endothelial progenitor cells in the basal and functional layer of the endometrium. The surface endometrium is the most critical component of the endometrial selectivity. The stroma does not have that selectivity which surface epithelium has got. The endometrium ensures trophoblast invasion but does not allow to cross the limit. Endometrial functions are progesterone, androgen, glucocorticoids, and insulin. The chains of the events in the endometrial cycle. The estrogen priming of the endometrium is done by the estrogen secreted by the granulosous cells of the developing follicle or externally supplemented estrogen. Because of the estrogen, there is endometrial proliferation. And second function is induction of the progesterone receptor. Once the endometrium is exposed to the progesterone, brings down the regulation of ER alpha 1 receptors, brings cellular and biochemical changes, converting the endometrium from proliferative to secretory phase, which leads to endometrial receptivity. Estrogen and progesterone receptors are responsible for 70%, and only estrogen is responsible for 30% of the gene expression which are responsible for implantation. The estrogen induced molecular and cellular events are not time sensitive, unlike progesterone. The follicular phase may last between days and weeks. Now about the evolution of the endometrium. Which are the points we take into consideration when we are evaluating the endometrium? One is EMT, that is endometrial thickness. Second, the pattern or echogenicity, you can say. Third is volume. Fourth, surface area. Fifth, vascularity. Sixth, looking at the endomyometrial junction. And last but not the least, the endometrial contractility. The endometrial thickness, to measure the endometrial thickness, the sonography is the most rapid, non-invasive, and handy economical test. The endometrial thickness is measured conservatively 1 centimeter below fundus at the thickest portion. But you have to understand that whole length of endometrium from fundus to the cervix will be visible before taking measurement. If there is an endometrial collection, the diameter of collection should be deducted from the measurement. The most accepted cutoff of endometrial thickness in non-IVF cycle is 6 millimeter. Fresh IVF transfer is 8 millimeter, and anything more than 7 millimeter for frozen embryo transfer. The endometrium grows at the rate of 0.5 millimeter per day in the proliferative phase and approximately 0.1 millimeter per day in the luteal phase. Of course, when the endometrium is exposed to the progesterone, firstly, there is a compaction of the endometrium, and later on, the size is increased minimally day by day. The endometrial thickness has got very high negative predictive value. Less than 6 millimeter is associated with the 100% negative predictive value for conception, but positive predictive value is poor. The thicker endometrium cannot ensure the best receptivity. In the largest retrospective cohort, including a total approximately 20,114 FET cycle, the clinical pregnancy and live birth rate, which were observed to decrease with each millimeter less than 7 millimeter. The live birth rate was 28.4% when it was measuring 8 millimeter, 27.4 when then the measurement was between 7 to 7.9, 23.7% when it was between 6 and 6.9, 15% when it was between 5 and 5.9, and 21% when it was 4 to 4.9 millimeter. Now you can observe that there was a reasonable outcome even when the lowest endometrial thickness was achieved. Live birth rate remained fair, approximately 15 to 21% among the patients with endometrial thickness, which was measuring 4 to 6 millimeter in FET cycle. But a recent large retrospective study of more than 10,000 cycles, they have suggested that the cutoff point should be not 7 or 8 millimeter, but it should be 8.7 millimeter. While evaluation of the endometrial pattern, we consider the endometrial pattern described by Grunfeld. So there are three types of endometrial pattern. Endometrial pattern A is late proliferative endometrial pattern, where hyperechoic endometrium is less than 50% of the thickness with the hyperechoic basalis and hypoechoic functionalis. There is very good vascularity observed in endometrial pattern A. The pattern 2 or B, you can say, is the early secretory. When LSR, it is exposed, early exposure of progesterone, or you can say the LSR has already initiated. So in this, there is a hyperechoic basalis and functionalis, which is extending to more than 50% of the thickness. And third is mid or late secretory pattern type 3, where there is a homogeneous hyperechoic functionalis extending from basalis to the lumen. Now, what is the significance? What is the correlation with the receptivity and endometrial pattern? Grade A is receptive endometrium, a triple line appearance or multi-layered endometrium on the day of the ovulation trigger. Grade B is a progesterone secretion initiate the chances in the endometrium, changes in the endometrium that are reflected as a homogeneous character near the junctional zone and a well-defined central echogenic line. Grade C is non-receptive, a homogeneous appearance of non-multi-layer endometrium. Now, something about the endometrial echogenicity. The hyperechoic endometrium is defined when grayscale is 10% higher than surrounding myometrium. When the ratio of hyperechoic endometrium is less than 60% on OPU plus 2 days, the chances of implantation is low. So, they have advised to freeze the embryos as suggested by the author of the study. The endometrial niche is present in 60% cases after LSCS. The 46% of them have fluid collection. The endometrial thickness is not necessarily affected, and pregnancy rate without niche is 47.6%, and pregnancy rate is reduced to 37.5% when niche is present. So in patient with previous LSCS, chances of implantation is reduced in a couple of cases. So when you're selecting a surrogate, you have to consider this point when you're selecting the surrogate. The endometrial contractility. There are constant waves in the endometrium. So what is the significance? Endometrial waves are more accurately seen in the cine mode or elastography. The early follicular wave is fundal to cervix, and late follicular or periovulatory wave is cervix to fundus. During early secretory phase, there are maximum 2 waves in a minute. The importance of this noting down wave is in the recurrent implantation failure when the patient is complaining of cramps around the embryo transfer, or when you're planning the timing of the ET after initiation of the progesterone. They have suggested that though if the number of the waves are less than 2 to 3 per minute, but if the waves are more, give extra dose of progesterone injection intramuscular in the evening and check for the waves in the next morning. And if the waves are less than 2 to 3, then you can thaw embryo and proceed for the embryo transfer. The endometrial volume is ideally more than 2 ml. The smaller volume is noticed in hypoplastic uterus, unicornuate uterus, and following tuberculous endometritis. The histoscopic metroplasty, which is followed by second look histoscopy with the clearance of the minor adhesions, and endomestradiol supplementation for few weeks may be beneficial. Different authors they have noticed, they have come out with the evaluation score, which takes into account the endometrial thickness, endometrial type, endometrial peristalsis, endometrial and subendometrial blood flow, EV, endometrial volume, and VFI, which is measured by 3D. Uh, the endometrial hyperplasia, it is interesting when you're coming across the case of endometrial hyperplasia. There are certain correctable correctable etiological cause which should be considered, like obesity, diabetes mellitus, PCOS, and smoking. So these are preventable, or you can say a correctable problem when there is a hyperplastic endometrium. When you're doing hysteroscopy, your aim should be to find out any pathology in the endometrium. And latent tuberculosis is very important to rule out, especially when there is a persistent thin endometrium. There is no appearance which can be described as diagnosis of tuberculosis. You may find pale endometrium, intrauterine synecdoche of varying grade, completely obliterated cavity, 80% by adhesions, granulomas, poor distensibility, narrowing of the uterine cavity. So these are the varied picture of latent tuberculosis. If there is a severe endometritis, there is a permanent damage to the basal endometrium or vigorous curettage, which leads to synecdoche, and which causes amenorrhea. And this basal endometrium cannot be regenerated. The HSG and sonosalpingography is not a reliable method for endometrial evolution, except there is an association of the space occupying lesion like adhesions or polyp. Now, what is implantation? The embryo implantation is a complex and multifactorial process which resulting from the crosstalk between embryo and endometrium and can be influenced by hormonal, molecular, and cellular events, as well as many other facilitating factors such as cytokines, cell adhesion molecules, transcription factors, and growth factors. The successful implantation not only requires a good quality embryo, both morphological and genetic, a synchronized dialogue between maternal and embryonic tissue, but also a receptive endometrium. The receptive endometrium, why it is important? The ongoing pregnancy rate with the euploid embryo transfer of 45% for a general infertility population and 60% for donor egg embryos. The one-third of top quality untested embryos implant and 15 to 20% of the embryos lead to a birth of healthy baby. That means that the factors other than the chromosomal abnormalities are responsible for only 40 to 55% of the failed pregnancy. So recently, the attention has been directed to endometrium in an attempt to optimize the chance of embryo adhering to and implanting in the uterus. Now, on the other side, let us think how important is the endometrium to the implantation. Take an example of ectopic pregnancy, where the endometrium is thicker, but the inner lining or endosalpinx, where the embryos are implanted, is quite thinner. Look at the in vitro growth of the human embryos up to day 14 without any maternal contribution. So, which again challenges that the only endometrial thickness or vascularity is important. There is something beyond that. Probably endometrium has a specific power to refuse the embryo to get implanted. What are the pillars for implantation and pregnancy? Broadly, for implantation, embryo, which is dependent on oocyte, sperm, and laboratory work. The endometrium, we consider thickness, texture, vascularity, receptor density, and receptive and synchronous development of the endometrium. Crosstalk, mainly balance between pro-inflammatory and anti-inflammatory cytokines, and immunotolerance by immunosuppression later on. And lastly, but not the least, the embryo transfer, atraumatic transfer, and again, lab work, which is important. So anything which affects this area can affect the implantation. The endometrial receptivity, what is it? The period of endometrial maturation during which the trophectoderm of the blastocyst can attach to the endometrial epithelial cell and invade endometrial stroma and vasculature later on is called endometrial receptivity. The implantation of the human embryo occurs only during the regulated implantation window on day 6 to 10 post-ovulation. After sufficient estrogen hormones exposure, initiation of the progesterone hormone starts a clock and the uterine lining passes through a receptive window of time when the implantation can occur. Before or after this window, implantation cannot occur. Despite enormous research in the field of human embryo implantation, the ideal marker of endometrial receptivity remains indefinable. Lack of accuracy, predictive value, and invasive nature of the biochemical and histological markers of endometrial receptor limits their clinical applicability. The endometrial, so the endometrial thickness and pattern still remains the most researched parameter for their predictive value in IVF. So what are those factors which can affect the endometrial receptivity? The oocyte recipient age, as the ongoing pregnancy rate drops as the age advances. Body mass index, high and low BMI increase the risk of miscarriage after IVF and ICSI. Endometrial thickness, less than 7 millimeter endometrium has decreased receptivity and hence the reduced implantation rate and pregnancy rate. Cigarette smoking, the infertile women who are smoker achieve significantly fewer successful pregnancy. And pathological conditions like luteal phase defect, fibroid, intrauterine adhesions, uterine septum, hydrosalpinx, endometriosis, autoimmune conditions significantly reduce the endometrial receptivity. Why implantation fails? If everything is fine, why it should fail? The endometrium, which plays a very key role, the endometrium acts as a biosensor of the embryo quality. The embryo may fail to thrive, fail to initiate implantation after thriving, fail to complete implantation after implantation has been initiated. The implantation is an immunological process which requires induction of proper tolerance levels, and if the tolerance is inadequate, it causes implantation failure or miscarriage. There has to be balance between receptivity and selectivity in the endometrial function. If the endometrium is too much receptive, it increases the pregnancy rate, but simultaneously the miscarriage rate is also high. And if the selectivity is high, there is a conception delay, but the miscarriage rate is minimal. The implantation window is the period during which the implantation is likely to occur. Blastocyst adheres and invades. It is not narrow as it was thought, especially when serum E2 level is not very high. So the important point to be noticed, the E2 level, you should try to keep a balance between very low E2 and very high E2. Empirically, you should not jump on pumping more and more estradiol without any reason. 98 to 123 hours of progesterone exposure for blastocyst transfer, there is no difference. So the euploid embryo tolerate altered window of implantation, which is very, very important to note and understand. I keep telling that embryo adjust flows of endometrium and endometrium accept certain flows of embryo. Now, how the endometrial and embryonic age is determined. The endometrial age is started from the time of ovulation or first exposure to progesterone. The vaginal administration of the progesterone results earlier and higher endometrial concentration. So ET is performed half day earlier than other cases, but practically we take this information in a such a way that when you are starting vaginal progesterone, at least you should not delay a transfer than a specific stipulated period. And the embryonic age starts from time of fertilization or assessment of the embryo stage. When the implantation reduces, when the discrepancy of embryonic and endometrial age is more than 1.5 days, there is no pregnancy occurs when discrepancy is more than 3 days. What happens when we give a clomiphene citrate to the endometrium? The CC occupy estrogen receptor all over, including the endometrium, so it inhibits the action of estrogen on endometrium. Low uterine PI has been documented after CC. If you start CC earlier, endometrium recovers till ovulation. If you're combining with the gonadotropin, effect on endometrium is less pronounced. Sildenafil vaginally 25 milligram QDS or estradiol 2 milligram BD orally following the course of CC improves the endometrial thickness, but not translated into increased clinical ongoing pregnancy rate. In unexplained infertility, the endometrium is thin, but does not affect pregnancy rate. A thin endometrium following CC and soft stimulation IVF protocol does not affect implantation. What about the endometrium in the lateral cycle? The estrogen receptors are unaffected in lateral cycle, unlike CC. It improves the vascularization and causes thicker endometrium. CC and letrozole both increases LIF gene expression, but only letrozole can translate into increase in the protein expression. Restores B3 integrin receptors necessary for implantation, inhibits the increased aromatase expression in case of endometriosis. The endometrium remains thin in unexplained infertility following letrozole without compromising the result. What is the effect of hyperstimulation on the endometrium? It may affect the expression of some markers and increased expression of these proteins may have a negative effect on the endometrium, may cause developmental retardation by inhibiting endometrial gland development, and can affect genes that cause dysregulation in the fluid dynamics. The ovarian stimulation may increase the abortion risk by reducing the expression of proteins that are effective in maintaining and protecting the gestation, decrease gene expression in which size they may have endometrial receptivity are thought to play a role in embryonic development. The functional endometrial differentiation, formation of a negative environment for optimal conditions of implantation. There are different methods for endometrial preparation in frozen embryo transfer cycle. The methods which are dependent on native source of estrogen, that is follicular source, is natural cycle, modified natural cycle, and stimulated cycle. And the methods which are dependent on exogenous source of estrogens are HRT cycle without pituitary downregulation and HRT cycle with pituitary downregulation. What are the important landmarks when you are doing natural cycle? The natural LS surge can occur anytime in the following scenario. The cycle day 12 onwards in 30 days cycle length, or earlier when the cycle length is shorter due to diminished sporadism. The follicular size, which is more than 16 millimeter, perifollicular vascularity covering more than 3/4 of the periphery, and PSV more than 10. Serum E2 level more than 200 picogram, serum LH level more than 10, and serum progesterone more than 1.75, or 50% above the average level during follicular phase. When to say that LH surge has occurred? Normally, LH surge takes 14 hours to reach the peak after initiation, and this peak is maintained for 14 hours and falls back to basal level in next 20 hours. The endometrium becomes more hazy and type 2. Serum LH level is more than 17 international unit, which is at least 180% above the average previous 3 days levels, and associated with the more than 30% fall in serum E2 level next day. Or to be more simplified, the single measurement of serum LH level more than 20 units. Progesterone level is expected post-surge up to 2.5 nanogram. So here this figure explains. Here the red line is estradiol and blue line is LH. So here on this day the LH level is highest. Here the LH level is lesser than this. Here estradiol level is highest and estradiol level for more than 30% on this day. So even though LH level is lower than this day is considered as a LH surge. How to predict ovulation? The ovulation occurs after 36 to 40 hours after blood LH surge and 15 to 24 hours after urinary LH surge detection. If you do a sonography, there is a follicle collapse with the size less than 14 millimeter, crenated margins, hemorrhage in the follicle, free fluid in the pouch of Douglas. And if you ask the patient, there is a subjective feeling of lower abdominal pain for few hours. The progesterone, once ovulation occurs, the progesterone levels start rising to more than 3 nanogram in 12 hours. The serum LH level is again comes back to less than 10 units. Serum E2 is again come back to less than 200 picogram, and endometrium becomes compact and type 3. What about the mid-luteal parameter? In mid-luteal natural cycle parameter, progesterone is more than 10 nanogram, which is maintained for 6 to 10 days post LH surge. And serum E2 level is more than 250 picogram. Now, when we are using SCG trigger, especially in like modified natural cycle, what are the parameters? So rise in blood SCG level is faster after trigger compared to a natural LH surge. The SCG rise peak takes 16 hours to reach the peak, and peak is higher than the LH peak of LH surge, natural LH surge. The E2 level rises up to 12 hours post trigger and starts falling. The progesterone after 12 hours is more than 3 nanogram or more than 2 times of pre-trigger level. The progesterone rises 5 times of pre-trigger level in 24 hours post-trigger. The progesterone level after 12 hours of trigger is more than 6 nanogram, which is suggesting a closer of window of implantation. The progesterone starts declining from the 6th day of the trigger and falls to the level on 8th day lower than that level of natural cycle, which is the actual implantation period. So post SCG, this is a a black spot where the progesterone level is actually less than a natural cycle progesterone level, and which is the actual period of implantation. Now, how natural cycle is done? The principle of natural cycle that there is no medication is used, and we rely on spontaneous LS surge and or ovulation detection. Start USG monitoring of the follicle 18 days before the expected date of menstruation. Keep doing urinary LS surge or serum LH level and E2 level, and document ovulation by doing repeated scan, and make sure that endometrial measurement is more than 7 mm. Now there are different scenarios while monitoring the natural cycle. If the ovulation has occurred within 40 hours of blood LS surge or within 24 hours of urinary LS surge, the endometrial age starts from the ovulation, and embryos are thawed and transferred accordingly. If the LH surge or ovulation not detected, cancel the cycle or directly start progesterone and or directly start progesterone, and the endometrial age starts. Patient won't have benefit of natural cycle, and it will be like HRT cycle only. The third scenario, if LS surge detected but ovulation has not detected, start progesterone 40 hours after the blood LS surge or 24 hours after the urinary LS surge, and endometrial age starts. What about the luteal support in natural cycle? If the ovulation is detected within the time limit, you may not start progesterone for 2 to 3 days. Only dydrogesterone 10 mg TDS should suffice. If the ovulation is not detected, vaginal or injectable progesterone is added to a dydrogesterone. Now, what are the pros and cons of natural cycle? The regular cycle does not mean regular ovulation always. So sometimes cycle needed to cancel. The LSA determination is complicated with intercycle and intra-patient variability. Urinary LS surge predictor kit has false negative up to 30%. The extensive monitoring is needed in this method. Very low estrogen and progesterone needed in the secretory phase with normal endometrial function for implantation and placentation. The endometrial gene expression pattern at implantation is similar to a fertile control woman, and window of implantation is longer than HRT. That is a very, very important and crucial point of natural cycle. Now about the modified natural cycle. The principle is to use trigger for the ovulation. So if the follicle has reached 18 millimeter, it is more than 8 millimeter, it is more than 150, and P4 is less than 1.5 nanogram without LH peak. Now we know what is LH peak. Either start progesterone and transfer embryos accordingly, or give SCG 10,000, but that is to be given in the night time. For better precision, pre-trigger progesterone, LH, 12 hours post-trigger progesterone, 24 hours post-trigger progesterone measured, and daily scan done to document the ovulation. The endometrial age starts from the ovulation if it is happening within 38 hours of trigger. If the ovulation is not documented within 38 hours of trigger, progesterone to be started and endometrial age started. If the ovulation not documented, but the hormonal levels suggested that either LS surge has occurred before trigger, the endometrial age is started earlier, provided the serial progesterone is increasing as per the criteria, or cycle may be cancelled depending on the levels. The trigger day LH is more than 70 international unit, progesterone more than 2.5 nanogram. If 12 hours post-trigger progesterone is more than 6 nanogram, cycle is cancelled. What about the luteal support? The progesterone threshold for secretory transformation is just achieved 12 hours of ovulation, that is 5 nanogram. If the ovulation detected within time limit, you may not start progesterone for 3 days. Only dydrogesterone should suffice. And if the ovulation is not detected, vaginal or injectable progesterone is added to dydrogesterone. What are the pros and cons of modified natural cycle? The less sonographic monitoring compared to a natural cycle, unexpected ovulation can occur, so accurate planning of cycle becomes difficult, resulting in the cancellation in 7 to 12%. The P elevation happens in 25% of the cycle, which does not matter much in result. The endometrial expresses the HSCG receptor and SCG trigger increases the VEGF and cascade of events which is necessary for implantation and presentation. LS surge before trigger does not require to cancel cycle, but to modify the cycle. And extensive hormonal monitoring versus only